I call upon our first speaker, Dr. Himanshu, and I invite Dr. Matthew Joseph, Dr. Shyam Babulkar, and Dr. Vasant Dakwale to chair the session.
टाइम मैनेजमेंट करो यार आगे से बढ़ रहे हैं लास्ट सेशन के बाद people don't manage person तक बोल दे बेटा
doesn't matter come
after covid you never
धीरे हां
इधर से जाने से 2 minutes और लाइट
नहीं होगा इधर आ जा इधर से पीछे बैठ जा
Yeah, Himanshu, you just start. Sure.
thank you
reduce time but finish it
yes I think yes we should restrict to time
2 minutes will be reduced each lecture.
Absolutely.
to understand time now
And I'll try to justify and quickly finish off my simple talk. Thank you, chairpersons, for allowing me to start without all these formalities. My talk is basically divided into two parts, I would say. First, I'll talk about TBI in very few slides, and then sepsis. And the idea of this presentation was to come to an understanding as to what we should use, hypertonic saline or hypertonic lactate. Now, we are all familiar with hypertonic saline. And hypertonic lactate it's not a new solution, but yes, it's now over the years coming up. A brief background, we are all aware of the role of hyperosmolar fluids infusions in our neurosurgical practice. And the idea is to increase oxygen delivery, obviously, and to reduce the brain bulk, and reduce the ICP, and improve the CPP. That's the basic idea of using hyperosmolar therapy. Now, hypertonic saline, we are all well versed with it. We are aware of how to use it. We know it comes in various formulations. It does not cross the blood-brain barrier, as it has a reflection coefficient of 1. We know that. It reduces the brain bulk. We are always concerned that it might lead to hyperchloremic acidosis. So hyponatremia is also a big concern when you're using hypertonic saline. But world over, it is being used. Now, hypertonic lactate is something I would say new, because we are not using it. It's not yet to come into practice. But lactate, which is present in this solution, is one of the physiological substances which is present in the brain, and it is actively used by the brain in abnormal situations, as you know, especially in head injuries. So lactate forms a major substrate in the injured brain cell, and it also induces vasodilation. Now, how does it reduce the brain bulk? It is hypertonic. Now, hypertonicity is separate, and lactate as a component is a separate issue. So, because of its hypertonicity, it definitely reduces the brain bulk, but the lactate is an additional factor in this solution, which is providing energy to the brain. But so far, we have most of the studies that we have so far are largely animal-based studies. So now in animal models, if we talk about hypertonic lactate, it has found to improve cognitive functions, the neuronal plasticity it has improved, and so it appears very attractive to use this fluid, and it maintains a neutral fluid balance, thereby reducing the need for blood transfusions, and therefore low risk of induced coagulopathy. So basically it has some therapeutic effect also, but all this has been observed only in animal models. Now this was one study which was carried out in human subjects, but it's a very small study. This study the idea was to see the effect on ICP, CPP, brain oxygenation and metabolism, and also what are the changes in the arterial blood chloride and pH. So, but this study was carried only on 17 patients. So it's a very small study, and the authors, they concluded that if you see these graphs, you know, the green and the red, green is hypertonic saline, and red is hypertonic lactate, the one which we are interested in. So you'll see they're both going parallel. Everything is going parallel if you see the ICP. So what did these authors conclude? That they supported the concept that hypertonic lactate may be a valid alternative to hypertonic saline, but it is only based on 17 patients. So what inference do we get for TBI? That hypertonic lactate has emerged as a promising therapy. Yes, we can say it is a promising therapy in management of TBI, as it has shown beneficial effects in terms of endocrine and metabolic modulations on secondary brain injury. Now, it affects it has modulated several things. It affects the blood-brain barrier. All these factors have been noted in animal studies. And as I said, it has been found to have a potential influence on the cognitive functions of the animals. So this looks very attractive. Now let's move on to the second part of the talk, which is sepsis. Sepsis, we know it comprises of various it has various components, but the major thing is what we are concerned is the circulatory component. So the circulatory dysfunction remains the focus when you are managing a septic patient. And the idea is to have an aggressive goal-directed therapy. We don't want to overload the patients because we know overloading, again, it is deleterious, it has harmful effects, and it is also related to the mortality, the outcome. Now there were studies, the HYPER-S2S study and the Heracles trial, where hypertonic saline was used as a resuscitative fluid, but it did not show any beneficial effect. There was no beneficial effect so far as the outcomes were concerned. And when hypertonic saline was used in patients with sepsis. Now, Duboc, recently the study was published, but again, it's on the animal studies. So this study was published where hypertonic lactate was used. And the researchers, they showed that DIC is associated with, which is associated with sepsis and causes a renal microvascular thrombosis. All these things were prevented and it improved the renal function. But there is scant evidence even now which suggests that hypertonic saline is associated with fewer perioperative complications, shorter ICU stay, and better survival. So we do not have enough data on this. And hypertonic lactate, additionally, it improves the cardiac performance. Now there are studies, again, they are very limited studies, but these features have been observed with respect to these two fluids. Now concerns do exist with hypertonic lactate. For instance, in this last point that you see, that's the ovine model of septic shock. Here the hypertonic lactate administration was associated with more pronounced decrease in the blood pressure and cardiac functions. So you see we are getting mixed results. And all these studies are either animal models or they are retrospective. If they are human studies, they are retrospective or with limited numbers, as I said. So if you talk about sepsis and the role of hypertonic lactate, the inference that you can derive from all the studies that have been published so far, that isotonic balanced crystalloids, not the saline, the isotonic balanced crystalloids, they should be used for resuscitation fluids in patients with sepsis and septic shock. Obviously, overzealous administration of hypertonic saline may contribute to hyperchloremic metabolic acidosis. We all know that. And hypertonic saline and hypertonic lactate, especially the hypertonic lactate, they deserve to be evaluated as resuscitative fluids in large randomized trials enrolling selected and a homogeneous patient population, choosing the appropriate control fluid. So that's the crux of these two fluids in sepsis. So the final decision is again up to you, which one you want to use, but so far as a final statement, what I can say is that there is no consensus on any particular fluid. So it could be hypertonic lactate or, but lactate I'm not sure if it's available.
Gram-negative septicemia, there is already lactic acidosis,
Yeah.
and you are not doing lactate.
Yeah.
You have not studied lactate and loading with more lactate.
Yeah.
Yes. You have gone
Bad to worse, yes.
So if
So
you are
it's-
not doing the metabolic assessment,
Yes,
giving blindly lactate will be harmful.
it will be very harmful.
Any other questions from the audience?
Like for hypertonic saline, we have serum sodium to monitor. For lactates, do we
Serum
have a
sodium.
parameter?
You'll have to monitor the lactates as well. Yeah.
Serum lactates is commonly
Yes, yes.
available.
Yes.
Yes.
And do
You
you
can-
have a target, as we have 150 sodium? So for lactate, what is the target?
So we generally don't want to go, now this is different because we are talking about the cellular level and in the serum level. So that will be different, but for so far we are only doing the serum levels. So that is up to not more than 2. We don't want to go it above 2.
And theoretically, we say that lactate also gives energy to the brain cells.
Yes.
That is the added advantage of lactate.
That's what is being proposed. Yeah,
Postulate.
yeah.
So we have to wait for some good studies
Yes.
before we can start.
Yes.
But otherwise, one or two questions regarding hypertonic saline. When we give hypertonic saline, can we omit mannitol?
Okay.
This debate always remains whether to use this or that.
Sugar or salt?
What I mean to say is that mannitol, apart from being a osmotic agent,
Yes.
does it also have other positive points
Mannitol?
which
Yes.
hypertonic saline doesn't have?
No, I think we are
What I
going
mean to say is
beyond.
that hypertonic
I think,
saline.
Dr. Tushar, that will go,
So-
that's a whole different debate.
Yes.
Sugar or salt
Mannitol-
debate is a whole different
Yeah,
debate.
mannitol has a lot of plus points. Hypertonic has a lot of plus points.
Because when I start hypertonic saline, I don't give mannitol. Is it right or wrong?
No, you cannot give both together.
No, sir. That is what the debate is.
We do, no,
They don't
we do,
need
yeah.
either
Okay.
this or that.
Himanshu, one more question. If you have, you're giving hypertonic saline, you want to raise the sodium, but you've got hyperchloremia, what will you give? You're already your chlorine is, your chloride is already 120.
Hypernatremia is there.
You want, but yes,
Fluid and Lasix.
So,
Give
no.
more fluids and Lasix.
so what would you give?
we have hyponatremia.
I have hypernatremia. I mean, I'm trying to achieve hypernatremia, but on my path, I'm at 140 and I've got 125 sodium already, chloride already.
Yeah.
Now what do I give? I want to raise the sodium some more, but my
Probably
chloride is
normal-
already high.
Probably normal saline.
That's
maybe.
also going to give me chloride.
Yeah, that will cause that. So that's a tricky situation.
You advocate hypertonic lactate to be given. So is it readily available?
No, not yet. It is there, but I'm not sure if it's in India. It's not available. I searched, but it's not available in India.
Okay,
Okay.
thank you. I mean, I have more things to ask you, but I'll ask you later. Okay, I don't have a list of the program.
Dr. Takash?
Yeah.
Dr. Takash? Next speaker.
Infantile head trauma.
Cautions,
Yeah, it's a good story.
cautions and faults
No, no.
in craniotomy.
No. Okay, Dr. Kash, thank you. Please, can you start, please?
Sure, no problem. I hope my talk will help you, doesn't make you feel hungry. Please enjoy my small talk. This is my topic in my. I try to investigate how the coagulopathy will influence the outcome, final outcome of severe traumatic brain injury, especially in infant. The objective is here, as you can see, children have different features in many respects, from anatomical and physiological level. So then, what I really want to know is that whether the craniotomy itself can exacerbate the pathophysiology of the children in infants, mainly infants, in acute stage of TBI, with systemic complications such as increased intracranial pressure and unstable hemodynamics and coagulopathy. And we enrolled 54 children admitted to our PIC, pediatric ICU, during the 23 months. Okay, so we divided all the patients into two groups: conservatively treatment group and surgical treatment group. In order to examine the influence of intraoperative blood loss, I created a breathing index. So I'm going to explain to you. But beforehand, I just recorded these clinical parameters on arrival, vital signs, arterial blood gas, and coagulation tests. Mainly, I used the D-dimer to know the level of hyperfibrinolysis. And also that I recorded the injury severity scale and the intraocular parameters. We can check the length and the significance of hypotension and the usage of vasopressor and hypoxia, history of hypoxia, and total volume of blood transfusion. Okay. I'm going to explain to you about this is a blood breathing index. So the first time we calculated the expected circulating blood volume. This is based on the body weight. Body weight times 0.2 times 1,000 is equal body weight times 200. If loss of 15% of this volume can result in a hypovolemic shock. So therefore, we determined that the allowable volume bleeding index as body weight times 200 times 0.15 cc. So then we created the bleeding index is counted in intraoperative bleeding, actual bleeding volume divided by allowable bleeding volume. So then, for example, if the patient's body weight is 8 kilo, allowable bleeding volume is 240 cc. So that we can, prepare for that enough amount of blood transfusion before we send to the infants to the operating room. So then, if the counted intraoperative bleeding volume is increased, and if the index is became increased greater than 1, I think that this blood volume can cause a hypovolemic shock. So it can turn in to the probably the poor outcome. And here's one of the examples of a patient, and it's the same patient I showed you in another my talk. This is the abusive head trauma case. Body weight is 8. So then we estimated that his avoidable bleeding volume is 240 cc. So we prepare for the enough amount of blood transfusion before we go to the OR and started the blood transfusion before we cut started incise the scalp. And carefully, we usually use the bipolar to incise the scalp and not to try to make a periosteal membrane from the bone to avoid unnecessary bleeding, venous bleeding from the surface of the skull bone. And here's another example. We take off the bone. Usually, you will see that the small leaky, fluffy bleeding from the surface of the dura. We don't usually cut the dura so widely, try to avoid that unnecessary blood loss. And we try to finish our operation within 2 hours at least. Then in this case, I counted the intraoperative blood loss as 50 cc, so which means that the bleeding index is 0.21. So that we try to make a comparison between C group and S group. In terms of the best PCS, we didn't see that there any significant difference between C group and S group. Vital sign, there was no significant statistical differences. And SpO2 and ISS, if you take a look at the ISS, probably I think a neurosurgeon tend to operate the more severe cases. How about the D-dimer and the fibrinogen? In the S group, showing us that the much higher level of D-dimer, which means that we have to operate more very dangerous cases, we can tell. About the PCPC, this is a performance category scale as a long-term outcome. We couldn't find out the very significant statistical difference between 2 groups because our research is on the way right now. But we did a study onto a surgical group. Intraoperative bleeding was much higher in acute subdural group compared to the epidural hematoma. And the bleeding index was much higher in the acute subdural group. So then we have to be very careful when we do the evacuation of the hematoma from the infants. In summary, the craniotomy tends to be performed the coagulation abnormality, and especially for the acute subdural, intraoperative bleeding volume was significantly larger, and the bleeding index was also significantly higher. So then I recommend, I believe that hasty craniotomy should be avoided. Try not to make a table death. If the bleeding index is greater than 1, then what's going on? Probably I think we need to continue to do this research from now on. So hopefully, I'm assuming that, I'm expecting that probably we can provide it more and more good outcome if we try to not to make unnecessary bleeding. Here's one of the design during my operation. I tried to make enough distance from the midline to the edge of the craniotomy. not to injure the superficial sinus. Once we injure the superficial sinus, because the children, in babies, the scalp is very easy, very unstable. So sometimes we miss the midline. Then they cut the superficial sinus, can cause a really hazardous result. And here's another example here. Okay. Anyways, I try to make a long story short. We try to avoid that making secondary brain damage resulted by the unnecessary intraoperative bleeding and also that ischemia or hypoxia, rather than very speedy evacuation of the hematoma. Okay. Okay, here's the result. Again, hasty craniotomy should be avoided. Cautious pre-op evaluation, intra-op management such as blood transfusion, careful hemostasis are very essential. Thank you very much.
Hi, thank you, Dr. Takashi. Any questions from the audience?
What do you consider massive blood loss? Massive blood loss.
How to manage? Okay, mainly, so following this formula, we estimated this allowable blood bleeding loss, and then asked the anesthesiologist to start the blood transfusion immediately, intubate the patient. After immediately the patient was anesthetized. With more probably I think as quick as possible, we ask the anesthesiologist to start the blood transfusion before we start the craniotomy.
You know, one of the major problems is the disagreement between the surgeon and the anesthesiologist on how much blood has been lost.
Yes, that's
the surgeon says 200 ml, the anesthesiologist says 1 liter is gone. So which one do you take for your bleeding index?
Well, I mean, like, the reason why I started to investigate this, I started to do this research is that I wanted to persuade the anesthesiologist to start the blood transfusion immediately after we asked the blood transfusion. Sometimes anesthesiologists are really hesitating to accept our request. So then I wanted to show some like a clinical.
They always have overestimated blood loss, and the patient gets unnecessary transfusion.
Fair enough.
In that case, auto transfusion.
Yeah.
You said whatever blood loss you collect by cell saver, don't tell me that you are getting outside blood. Auto
That's for a child, small child.
And also,
you can do that.
Yeah, it is for an adult one.
Because one of the paper in International Society of Pediatric Neurosurgery from Italy, about 25 years back, they were talking about children. You can collect blood from anybody. Whoever
Yeah.
is using, the only time the catheter collection will be smaller.
especially the
Like 100 ml blood, filter it is worth.
well, anesthesiologist who's working at the children's hospital usually not to try to avoid that they try to avoid unnecessary blood transfusion. Yeah, because of
How
the
many people you know
complications.
use cell saver? How many people use cell saver?
No.
Cell saver, cell saver. How many? In 1991, I purchased 2 cell saver worth of $25,000 because we did not want to have unnecessary blood transfusion complications. I think you should have cell saver so that you take the blood collected from the patient bleeding and filter it and give it back.
Okay, we'll have one last question. Yes.
You mentioned that the moment your bleeding index goes beyond 1, the patient is at a risk of going into hypotension.
Yeah.
So suppose there is a consensus between the surgeon and the anesthetist, and the bleeding index goes beyond 1. Would you wait for some features of hypotension or maybe at least tachycardia to set in, or you would start transfusion?
I think I would start transfusion first.
Right.
Yeah, but I think this is a
Manifestation of shock.
this is a retrospective study. So then I think bleeding is just
Secondly, apart from the total body weight which we use for calculating the blood index, will the pre-op hemoglobin will also be taken into account? Because a lot of these kids will have a lot of scalp hematoma, they would have already lost blood, and the hemoglobin and the mean corpuscular hemoglobin concentration will be different.
Yeah. Also, we can ask the anesthesiologist to give them like a frozen plasma, FFP, yes, frozen plasma. So that's another reason.
That's for the coagulation, but most of the anesthetists, when they cause the maximum permissible blood loss, they also take the preoperative hemoglobin and MCHC into account.
Yeah. So that I wanted to make sure that this is a very important concept. Try not to make blood loss, and also that this can cause a very hazardous secondary brain injury. So I wanted to make sure that if there's any relation between this.
Thank you. Thank you, Dr. Kashyap.
Okay, thank you.
Dr. Mahapatra?
Actually, we have to speak. Good afternoon. I don't know how many of you know the development of neurosurgery in India. The formative stage, then consolidative stage, then super specialist stage. We wrote a chapter, Neurosurgery Prospect and Retrospect, when Dr. Kak was the chairman of that book, and we divided 50 to 70, 70 to 90 and beyond 90, because it's all super specialization. Neurotrauma, pediatric neurosurgery, skull-based surgery started after 90. So there is 3 distinct phases, and so also the neurotrauma. So if you see before independence, these are all mostly by general surgeon. Only in the army hospitals during the Second World War, they had some neurosurgeons doing neurosurgery for the brain injury. So this is British neurosurgeon. But we rapidly developed neurosurgical centers. So first credit go to, of course, Vellore, then Chennai, and neurosurgery developed in the south and west much better and faster than the east and the north. So that is what happened. So phase 1, phase 2, phase 3. This is Ramon Lamba case, who died there because nobody operated him for his head injury. So in Asia, if you look at about 1988, there are only few I think Pakistan had 4 neurosurgeons in 1986, and Bangladesh had 1, Rashid. So if you imagine, we have exponential number of has gone geometrical progression. So we have expanded. So now we have 4,300 neurosurgeons. So first phase between 1950 to 1970, 53. And from 1970 to 1990, 350. And now last 20 years, 4,000. So the question is that how much you need? Do you need more or less? I think even today, no district headquarter will have neurosurgeon. So average people that have to travel very long distance, nahin? So average distance may have to be 100 kilometers, because most of the, I don't think all medical college have neurosurgery. So we have to see that how much is enough and how much should do, because the question arises, how many trainings are adequate? When I was chairman in MCI postgraduate committee, that is 2006 to 9, I told about 500 training per year is good enough. That time we are giving 170 MCH, and around DNB I calculated another 150. Somewhere 280 neurosurgical training, both MCH and DNB. And we saw that cardiologists are trained 300 per year. That's 2006. We are training 300 cardiologists, 170 neurosurgeons. And what happened? The cardiologists are overnumbered in the country, and now they have taken less. What has happened last 2 years? Neurosurgery resident posts are vacant in India. Do you know that? No. Even in AIMS, different AIMS, neurosurgery resident posts are not vacant. More than 3,000 posts are super specialty and sub-specialty posts are vacant, because no taker, people don't want to come neurosurgery. If this happens for 10 years, you will have vacuum of neurosurgeon after 25 years when the people retire. So we have to understand need, and by that time population will be 1.7 billion. So data is not available detail, but we know that we have need more training centers. And what training centers? Because we are now super specialist stage. We need more pediatric neurosurgeon. Yesterday we were talking about trauma surgeon. People would not like to trauma. But trauma should be a part of basic neurosurgery training, where everybody should have 6 months training in trauma. Many centers in India do not like trauma. You know that we know many centers, they say trauma, send to another hospital. This is not our case. But now the things probably have changed, and even you have trauma, you do not have good ICU care. If you read the data, the world population and the number of beds in India is lowest 10 in the world. Population to bed, bed to doctor ratio, doctor population ratio, 3-star parameters. We are only on the lowest 10, and the number of countries which are worse than that, Ethiopia, Congo, and some African countries. So we feel proud that we have done well. We have done well, not up to the expectation. So things have changed. So 70s, what happened between 70s and 90s? We developed anesthesia care. If you would have seen 70s, there were no ventilators. I remember when I was a medical student, the doctors are dying without ventilators. It is 2006, in 100 years of Lucknow Medical College. A medical student fell down from a stage and he had head injury. They did not have a ventilator. The patient had to go to Sanjay Gandhi. And it was big news that Lucknow happened after having 100 years of medical college, 2006 from 1906, when the King George V visited India, the 5 medical colleges started. And one of them was King George Medical College, Lucknow, but they didn't have ventilator. So I knew that when I was in Sanjay Gandhi, we had about 100 ventilators because we had critical care, neuro care, cardiac care, but they were trying to struggle for 2 ventilators. That is 2006. So the question is that we have to develop ICU care. So even the neurosurgery has developed well to some extent, we still, Dr. Matthew, we have to have critical care training and good, because all the result we are going to have neurosurgery and spinal surgery is the good quality care in the ICU. So now we have subspecialty, trauma centers, trauma guidelines. First trauma guidelines, Pushti is not there. We had a trauma guidelines in 1990. First trauma guideline, I don't know how many of you know, 1991 conference of NSI, we decided to have a subcommittee of Indian NSI. So Dr. Sambasima was president, chairman, and Dr. Ramani was the secretary. From 1991 to 1998, we have called NSI Neurotrauma Subcommittee. It is in 1990, Dr. Sehgal said in one of the NSI conference, why not an independent? I think Dr. Babulkar and Dr. Their friend is there. So I think that is the time Dr. Sehgal said, I think so are Neurotrauma Society of India. Lot of credit goes to Dr. Ramani, Dr. Sehgal and Dr. Banerjee, because they were very much initiated in neurotrauma, and they say unless you have dedicated trauma, the trauma care is not going to improve. I think we should give a lot of credit to these fellows. So advanced management, prevention, of course, we have not done a lot about prevention, because prevention is the best management of trauma. Helmet design, light helmet, aerated helmet, because if you ask the person who is wearing helmet, we are having a walk in Hyderabad, prevent neurotrauma, we put helmet. It was difficult for me to walk with that helmet. After walking half a kilometer, because we are supposed to walk 4 kilometers with a helmet. So I realized in that half a kilometer I have sweating at 6 o'clock morning. So imagine the person in 47 degree in Delhi, how can he travel? So we have no helmet properly designed, light helmet, aerated helmet, cooling helmet, and which doesn't smell. Because if you drive 10 kilometers with all sweating, after that smells. So we have to have lot of planning for, so let us say biomarkers. A lot of things talk about biomarkers, cerebral blood flow. I did a lot of study on the microdialysis and evoked potential. These are not necessary for management trauma. If you have it for research purpose is okay. So neurosurgery basically depends on good pre-hospital care and good ICU care. If you have ICU with blood gas, these are this is the first one, the guidelines for management 1995. We thought even a skeleton has to drive a 2-wheeler bicycle. He requires to protect his skull, which may not have brain. He will have fracture. So that is this was 1995. I don't know, many of you don't know. But anyway, I will stop here. Thank you very much. I think unless you prevent, whatever treatment you do, a lot of people will die.
Okay.
Nice.
Thank you.
Still I remember the beginning of Neurotrauma Society of India. You already
We are
told the
actively
thing.
this
1991.
91
What
control
is Hyderabad?
that was Neurotrauma subcommittee of NSI.
Yes.
Yes.
So not a people not yes.
Sir, you very nicely presented the talk. Now, all over to increase the facility of neurosurgery.
The seats are being increased. Every medical college we have written for enhancement of seats, and it is a dual role. It is a paradox rather. On one side, the number of seats, facilities, training centers are being increased. On the other hand, as you rightly pointed, even the MCI neurosurgery seats are being vacant. So how to bridge the gap? I
Actually,
request
we
the
have to
opinion of
encourage,
seniors.
actually most of the posts in the government sector are not filled up. Whether government agrees, they have no money. Believe it or not, government doesn't have money to pay salary. So the question is that they would like to have post whole granite. You know how many neurosurgeon posts in AIMS here? 27. How many are there? 21 or 22. 7 posts are vacant in the All India Institute of Medical Sciences.
That's why
and these posts were created by me in 2011.
Sir, but one more paradox is, and I do not fully agree with that. Government seats are also on rise. The government also is sanctioning seats in government institutes. All the residents in government hospitals are getting good hands-on experience. On the contrary, I am sorry to say, it is only my personal observation, most of the DNB courses are other PG courses in private. They are only confined to making grounds and following the seniors without hands-on experience.
I understand that you are telling that soft standard training is given in smaller places, right?
But they
and
are getting
number
filled.
should be quality rather than the number, right? So question I divide.
Both are important, sir.
I divide neurosurgery three parts.
Seats should not be
neurotrauma is 30%, neuro-oncology 30%, and 30% are vascular. Forget of pediatrics. They are the veterinary surgery. So if you think that way, do you have 30% of our neurosurgeon dedicated in neurotrauma? No. The question is that we like to have a rosy picture like clipping an aneurysm or taking a tumor or something. So neuro-oncology and vascular neurosurgery more pampered than neurotrauma. And next thing that a lot of people don't go to the
So my question is how to fill the gap. You are increasing the seats on one side, seats vacant on other side.
No, that is what people are all concentrated in Delhi. Let us say big cities. If you have 80 neurosurgeons in Bhubaneswar, Cuttack, in 50 kilometers away, there is no neurosurgeon. Puri is a major place. Puri is I think is a tourist place. But there is no general surgery even. The question is not for neurosurgery. If you see the deficiency, go to the analysis of April 2021, the gap in India. We have 68% to 82% gap for general surgery, general medicine and pediatrics. I am not talking neurosurgery. Even we have deficient of general medicine, general surgery. Question is that whatever you trained, if you do not employ physically them, they will be all staying in the big cities. Andhra Pradesh did good thing. 25 years back, Chalpati Rao told me all medical colleges created professor post. If you would have started a lecturer post, nobody will go. If you give somebody after 5 years or 10 years after neurosurgery directly professor, they will go and create a department. So unless our administration, our academician and junior participate in decision making, otherwise the people will always say neurosurgery is a super special, doesn't matter. People have no money for food. Gynecology get more priority than neurosurgery. Yes, they could do.
Sir, if the remuneration or the payments are better for the neurosurgeons,
that
will it
cannot be
attract?
done.
No, people are under the influence.
Political question.
Urologists, some other specialties, they are getting more money.
Vijay Shekhar, can we stop? We are running late, please.
One can always argue why central government gives
Not
more
argument,
money
sir, just
than the
my
state
concern.
government. No, that cannot be a consideration.
No.
Somewhere the service element has to come. If I would have been in practice, I would have been a different person. But I don't consider that should be the first discussion, right?
Okay, thank you, Dr. Organizers, when is lunch finish? No, when does lunch finish? When do you have to come back?
Half an hour.
Chalo. Thank
Not
you.
ready.
We have a lunch first, then see.
मैडम से एक फोटो निकालो मैडम